Hello everyone, and welcome to this recording of E&M Coding Changes for 2021. This is a re-recording of a webinar hosted by the South Florida Hospital News and Healthcare Report and presented on December 8th, 2020. We decided to re-record the webinar information in order to present it with less time constraints and more clearly because the information is pretty complex. So if you listened to the webinar the first time, welcome back. And if you're new to the recording, welcome. There are always housekeeping issues, so of course you're not recording this because we recorded it for you. But please don't photocopy slides and distribute them, but feel free to share the link to the YouTube recording so that other providers can be prepared. Originally, I presented the information, but Wilma Torres, CPC, and Erica Brewster, CPC, were available for the question and answer periods. So unfortunately, this time you're stuck with just me. Here's what we're going to accomplish in this webinar. We are going to review the changes to the E&M coding process for 2021, and they take effect on January 1st. So hopefully this is not the first time that you're hearing about this, but our expectation is that at least the explanation will better prepare you for these big changes. So we're going to explain how E&M coding in 2021 is going to differ from current E&M coding processes. We will look at the big changes to two areas. One is medical decision making, or MDM, and the other is time-based E&M coding. And just in case, E&M stands for Evaluation and Management. The last thing that we'll do is to discuss some action steps which you can take to be ready, or at least to position yourself in your practice for proper coding. All the registrants to the original webinar received a packet of materials, but if you're listening to this recording for the first time, feel free to email our company. I'll share that information on the last slide, but it's info@askccg.com, and we'll be happy to send you a packet of materials. Okay, so 2020 E&M guidelines, and these are for office visits. Coding right now boils down to selecting the appropriate visit level, which is then reflected in the payment that the practice receives for those services. At least this component that we're going to talk about. And right now there are three main areas that factor into the selection of the E&M code. I have to start out by saying that medical necessity is the overarching criterion for any visit that Medicare is going to pay for. If you come from the managed care world where you see a lot of capitated patients, well, I guess the medical necessity is inherent and you are seeing those patients because you're keeping them well. But when you're seeing a Medicare patient, it's important that the visit clearly reflect why the patient is coming in. And that's usually in the chief complaint section of the note, which is the reason why the patient is being seen. And so follow-up is not a proper chief complaint. Follow-up of what? And within the history section of the progress note, the HPI is one of the chief criteria for E&M selection, and this is where you elaborate on the complexity of the medical problems, give a chronology of things that have been going on since the last visit. There's also the review of systems, which right now in code selection impacts the code, because depending on the number of systems that you review, that just adds more heft to the complexity of the visit. But the review of systems has to tie to the diagnoses that you're assessing on that day, which really the stage is set in the HPI. From there, you've got past and family and social history, and these have always been reflected as they are relevant to the chief complaint. The next criterion for E&M selection is the exam. And the exam section has always been dependent on the judgment of the clinician and, of course, the problems that are being addressed on that day. And right now, the type of exam and the number of elements that you address on the exam correlate back to the chief complaint or the reason why the patient is being seen. The medical decision making is the last element of E&M code selection. And this has kind of three areas. One is the diagnoses. So providers think about and review the number and type of conditions, perhaps whether they're known or they're undiagnosed, how they are progressing. And from there, they look at some data, the number and type of pieces of information are relevant to the code selection. Of course, this all has to, again, match the chief complaint, the reason why the patient is there. And then providers are supposed to consider the risk of complications and the management options. And this is kind of a squishy area of documentation because, let's face it, everything that's in the provider's brain doesn't make its way into a paper note or a screen. And so the medical decision making is not always really laid out. In 2020, E&M code selection has to do with how many things you've assessed. You basically do a count, kind of give a look as to all these three aspects of medical decision making and come up with a code. Right now, E&M coding is driven by the guidelines that were released in 1995 or 1997. So the 1997 clarified some of the 1995 guidelines, and these provide more details on code selection. The biggest issue is that they're old. And of course, sometimes we do presentations and we find people in the audience who weren't born in 1995 or 97. Keep that to yourself. I can't deal with it. But medical practice has changed a lot in these years. And so the goal was to make the code selection process more reflective of the current state of medicine. You might be thinking, well, I was used to that system, so why are you changing it, CMS? Well, there are a lot of reasons for this overhaul, but the first is that CMS has some goals, and they really are to help providers. The complaint of the administrative nightmare that has become healthcare is not lost on the powers that be in the healthcare payment world. And so reducing the administrative burden is always the interest of any payer. We jump through a lot of hoops, reporting quality measures and tightening this and making sure our documentation is up to par. So that is one of the reasons why they're making this change. In addition to that, it's improving the accuracy of the payment, because E&M coding, after all of these years and 30 years of guidelines, there are still errors. And every year, CMS releases numbers that show their spot checks and how there are still 1.5 million or so, I'm trying to remember the numbers, of dollars that are improperly paid. And so upcoding, coding a higher level than you can support, and downcoding, coding a lower level, than is reflected on the note are both considered errors. And so to improve payment accuracy, they decided to simplify the process by which providers select those codes. And then of course, like I mentioned, updating the whole coding process and the codes themselves to reflect current medical practice. It blew my mind when I read that this started with a proposal to make changes to the 2019, that's right, Medicare provider fee schedule by blending the payments for levels 2, 3, and 4. You heard that. Blending, which meant that there would be one payment regardless of whether it was a level 2 visit or level 4 visit. It would be the same payment. I think I can imagine the outcry from perhaps the AMA and providers across the board that said, what? So that was scrapped, but the E&M process was still revamped. And so don't panic. There continue to be distinct payments for each E&M level, and that is going to continue. So this is good news. I forgot to click. This is good news for providers because the process is going to be a little bit more streamlined, which means that your documentation should be able to reflect more of the medical aspects of the visit as opposed to meeting requirements to select a code. So it should be a little bit, sorry, more reflective of how you think. And the bottom line is you get to spend more time with your patient eyeball to eyeball as opposed to typing and the patient's looking at the top of your head. So they hope that these things will reflect in less provider burnout, but we'll see how it shakes out, right? So here's an overview of the changes for 2021, and we'll go into each one of these in more detail. So first, deleting 99201. So that's not going to affect a lot of people, but it is a change. Second is, drum roll, the HPI and exam will no longer be key components. Remember the beginning? I mentioned there are 3 elements, and HPI and exam were 2 of the 3, and they're not going to be scoring elements in order to select a code. Don't think you're doing away with them entirely. We'll talk about that in greater detail. There will also be new definitions for medical decision making, and they're a little bit more precise. So maybe that'll help remove some of the squishy aspect of, wow, how do I reflect what's in my mind? Next is reflecting the new definition for time-based billing, which is pretty interesting. But here's the cool thing. With the 95 and 97 documentation guidelines, providers had to pick one or the other, and that was going to be the way that you would document and select E&M codes in your practice for everyone. The cool thing about this change is that the provider gets to choose whether the visit will be billed based on medical decision making or based on time. And you don't have to stick with one process for everyone every day moving forward. You can decide based on the unique aspects of that visit and your documentation which way you're going to select your code. So that's pretty neat. Then there are some new guidelines within E&M and also new definitions. So you're going to see that the AMA has really refined this process and given very specific information that should reflect in more appropriate coding. So deleting 99201 is one of those no-brainer things. This code is very rarely used. It's for new patients. It's the lowest level code. It has very little in terms of documentation components and varies very slightly from the 99202, which is the next highest code. It's a straightforward medical decision-making code. And because it's rarely used and doesn't differ a lot from the next level, it really was considered to be redundant. But the biggest thing that was surprising to me, because we review a lot of charts, is that those initial visits are generally well documented. So, high five, your efforts reflected in one less code, so maybe simplifying things a little bit. But the big one is HPI and exam no longer key components. But like I mentioned, first of all, medical necessity is still required. So you have to reflect that in the visit note. And remember, it's not the volume of the documentation that counts, it's the quality. So keep that in mind. The HPI and exam need to be medically appropriate. So you might be asking, well, what does that mean exactly? They're not going to tell you because that's in your mind as a provider. All I'll say is that it has to match the reason why the patient is there, which we know that many times a patient comes in for a minor issue and there's this huge long exam of things that were not relevant to the reason why the patient came in. So in this and sometimes they were done or they were reflected in the note because they justified a higher visit level. So right now, they really just they're up to you as a provider. What's appropriate based on what you're doing and what you're seeing with that patient. Some of the reasons why this change was made have to do with the HPI being documented by someone else. We know that CMS has allowed your medical assistant, for example, to document certain elements of the visit, like the chief complaint, the HPI, the review of systems. So along with that, the PCP really only needs to update the information or approve it. And so the feeling was that some of these elements are not really provider work. They're work that's done by someone else. So why should they be documentation requirements in order to select a code? The other thing is kind of like the bane of coders and auditors across the board is that the exam has become one big template. And I am not accusing anybody, but there are concerns that one visit looks the same as the next, looks the same as another patient's visit, and really the only varying elements are the vital signs. In addition to that, it's a little questionable as to whether 100% of the exam was actually done. Because of the templated nature, it's easy to click, 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 but only you know if you really did review every one of those elements of the exam. And so each note still needs an HPIN exam, but this is not going to factor in to your selection of the code. And I think, over the years, providers, it's been drilled into your heads from people like us that's like, oh, you've got to be clear, you've got to justify. And perhaps that's reflected in a little bit of paranoia, which probably is justified, and a lot of over documentation. So we're hoping that this is going to be kind of like a good breath for you to say, you know what, I don't have to jump through as many hoops. I can focus on my patient, why my patient's here, and that's what I'm going to reflect in my progress note. Last thing, the progress note is a legal document. It's part of the medical record, and so it needs to reflect reality. And you also need to cover yourself, right, in case of a lawsuit or a payer comes back and wants to recoup payment. So your note needs to still have information and heft behind it, but you get to decide what that is. Real quick, I just wanted to show you the current definition that goes along with level 3 visit. And the blue section says 3 key components: a detailed history, a detailed examination, and medical decision making of low complexity. That seems a little bit contradictory, right? But anyway, in 2021, it says a medically appropriate history and or exam and low level of medical decision making. So again, that's reflecting a little bit more in line with how you think, hopefully. So let's talk about how to select the code, an E&M code, based on medical decision making starting on January 1st. Remember that med decision making still includes the 4 types, so that's not changing. There's still straightforward, low, moderate, and high medical decision making. But the elements, well, and the elements don't change, but the information or their definitions do change. So we talked about right now, E&M codes are selected for medical decision making. There are 3 criteria, right? Diagnoses, data, and risk. Well, they're still here, except that the number and complexity of the problems also include the number of possible diagnoses and the number of possible management options. So there are a lot more things that you're thinking about when you're looking at those problems. In addition to that is the amount and or complexity of data to review and analyze. And if you look, they've specified, all right, well, what is that data? Tests, documents, orders, independent historians, which we'll explain a little later, test interpretation, and discussion of management and interpretation with external providers. So they've really added more precision, and I like the word, and I call your attention to the word analyze, because we know that providers review, and you probably analyze, right? But that analysis is not clear on the note. We don't see it. So this is an interesting kind of shift. And the third aspect is risk. This was expanded, or this definition expanded to include options that were considered but not selected. And that's got to make its way into the note. And of course, the aspect of shared medical decision making with the patient, family, or both. So these are things that you discuss, and you would document that you discuss with the patient or family member. The AMA's definition of risk really leaves things up to the clinician, and the definition is based on the usual behavior and thought process of a clinician in your specialty. Interestingly, with all of the evidence-based medicine that we've seen over the years, there may be probabilities inherent in a condition, and those are things that you should use when you document the aspect of risk that you're considering. But it's really, based on the consequences of the problems that you're addressing at the encounter when they're appropriately treated, if that maybe helps. Okay, so let's jump in. This table is from the AMA, and there's a document in the packet that we can send you that has the entire table, or you can Google it. It's called CPT E&M Office Revisions Level of Medical Decision Making, and it has all these little tables in one page, and it's really very helpful. You're going to see it throughout our discussion on all the levels of codes. So I'll call your attention to how you code based on medical decision making. Your documentation has to reflect 2 out of the 3 elements of MDM. Well, what are the 3 elements? Number and complexity of problems addressed, amount and or complexity of data to be reviewed and analyzed, and risk of complications and or morbidity or mortality of patient management. So it's still the same. That means you have to meet the criteria for MDM for a level 2 visit, as you can see here, based on something from this column, 2 somethings. So this and this, or this and this, any combination of the two. You'll also notice that the medical decision making is the same whether you're talking about a new patient or an existing patient, which, makes sense. I guess the biggest concern for us as consultants and chart auditors is that we believe providers are a little bit in a groove because you've been doing things the old way for a long time, racking up points in the review of systems and the exam that eventually boil into your selection of the code or your EMR's selection of the code. And so the decision making, a lot of times, that aspect of current coding is a lot of times supposedly inferred by the person who's reviewing your note. It's not necessarily laid out in a clear manner, but when we've discussed this with providers, it's like, well, it's there. Look at the medication list. Look at this. Look at this. But it's not tied together, like we always say, with a big red bow for CMS or any payer. And so hopefully your EMR has a good template to help you with medical decision making and making sure you have all of these elements. And I think the other concern is that these changes will require you as a provider to document your thoughts and your discussions, and not just about big things, not just about those, or for those patients who have really complicated problems and, you spend time writing out this whole narrative, but this is for every visit. So I don't know if that, I wish I had that little emoji with the big eyes popping out. Okay. All right, there it is. So for 99202, the number and complexity of problems is one self-limited or minor problem. What's a problem, you might ask? Well, the AMA says it's a disease, condition, illness, injury, symptom, finding, complaint. Whether you make a diagnosis or not, you are considering those, and those make their way into your documentation. So if you have one self-limited or minor problem, you have met, remember you need 2 out of 3, you've met one criterion for medical decision making that supports a level 2 visit. I'm going to try not to move my mouse too much so I don't make you dizzy. Next column here is in terms of data, there may not be any. So there might not be anything to reflect from this criterion. But then here, minimal risk of morbidity. So somehow you've got to mention something like that in your documentation. Self-limited or minor problem, a problem that runs a definite and prescribed course, is transient and not likely to permanently alter health status. So that's how you select a level 2 code. So let's look at level 3 codes. Again, same 2 out of 3, but things are going to get a little bit more complicated. So here it's like, well, 2 or more self-limited or minor problems. So instead of just 1 that you needed for the level 2 visit, now you need 2, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. And we'll look at those definitions on the next slide. But let's come over here and look at the amount and or complexity of data. First of all, the table says you must meet the requirements of at least one of the 2 categories. So you have to have one from column A here, or another one from here. And these say any combination of 2 from the following: review of prior external notes from each unique source, review of the results of each unique test, and ordering of each unique test. And we're going to talk about that in a minute. The other thing is you can add to your assessment with information from an independent historian. So what's an independent historian? Pretty much a family member or a witness or other person at the visit or that you consult who gives you information that you need, that gives you history that you need. Perhaps the patient has dementia or not a reliable historian, and you need to ask more questions. Well, that can factor in to the amount or complexity of data that you're reviewing and analyzing. But your note needs to make it clear. Just because you ask the wife information and the husband is perfectly capable of giving it to you doesn't let you meet that category 2 aspect. Interesting. Let's talk about what does it mean to address a problem? Because we see some interesting notes out there, you guys. Addressed means there is documentation of the evaluation or treatment by the clinician during the visit. And that can include, you're thinking about further testing, treatment's not elected due to risk or benefit, but that's got to be documented. So stable continue to monitor, if that is your way of documenting an assessment, that really isn't accurate and it's not appropriate reflection of your medical decision making, and it really doesn't say much. So consider if that is your pattern. Use this time before January 1st to make some changes. Let's talk about laundry lists, because we see those. And a laundry list or a shopping list is just one diagnosis after the other in the assessment. DM, hypertension, CHF, COPD, all in the assessment with no additional information. That is not a proper note. And if you work with us, we've drilled that into your head, I'm sure. So that's where saying, well, hey, look at the medication list. You can see what I'm using to treat these conditions. Look at all the medications the patient is on. No, not really, because we know that some medications can be used to treat several things. And so we need the provider to do the link. Tell us how the medical condition is doing and what medication you're using to treat it. The patient is stable on the current dose of glipizide or whatever, and her blood sugars are blah blah. Something. Addressing when you say that a condition is managed by a subspecialist, let's say, that is not assessment of the condition. What are you? And most of the time we're talking to primary care providers. So if you're the specialist, well then and usually you all have better documentation than primary care docs do. Sorry, that's just our experience. But when you say this condition is being managed by the cardiologist, well, what are you as the PCP doing for it? Because just writing a referral is not considered evaluation or addressing a condition. The other thing that I wanted to tell you is let's talk about unique. Right? What does unique mean? Well, it might mean something to you, but the AMA is very specific. Review of prior external notes from each unique source. Well, a unique source is a specialist. So if you look at 5 notes from the same cardiologist, well, that's one source. But if you look at notes from the cardiologist and also the GI, then those are 2 unique sources. Any combination of 2 from the following is the requirement. Review of results for each unique test. Let's skip to the next slide and look at some things. Well, I'll tell you the unique source. Come on. There you go. So let's talk about that and then we'll come back to the problems. A unique test is based on a CPT code. So let's look at a basic metabolic panel that has 8, I don't know, I've never counted them, 8 things in it. It's still considered one test. So even though you might be looking at the patient's glucose level and their creatinine and their GFR, and you're looking at 3 things, or maybe all the things, it's still considered one unique test. So here it says each unique. But if you are reviewing and analyzing the basic metabolic panel and a lipid panel, those are 2. Add a CBC, those are 3. But remember that your review of the results of each unique test have to tie back to the reason the patient is here, the chief complaint, and the medical conditions that you're assessing at the visit. So let's go back here. Self-limited or minor problems, we already know what that is because we talked about in level 2. One stable or chronic illness, well, the definition is something that has an expected duration of at least a year or until the death of the patient. And the term stable means that the patient is at the specific treatment goal that you established together for the management of his or her condition. One acute, uncomplicated illness or injury. Well, recent or new, short term, problem that's normally self-limited, a full recovery is expected, and so that is the definition of an acute or uncomplicated illness or injury. And then the risk of complications is low risk. So you need 2 out of the 3. You're going to probably pick the number and complexity of problems and then go through a process of reflecting these criteria here. Let's look at level 4 visits. Same thing. The level 4 visit is considered a moderate decision-making visit. Again, the number and complexity of problems includes some of the things we've seen before, and now there's a longer list, right? 1 or more chronic illnesses with exacerbation, stable chronic illnesses, which we just saw, undiagnosed new problem with uncertain prognosis, and I'll show you those definitions on the next slide. The amount and complexity of data stays the same definition, and they've moved things around. So here you can see that before we needed 1 out of 2, now we need 1 out of 3. So the complexity is starting to be reflected in the number of things that you need to pick from this section. And you'll note that these are the same, the first 3 are the same ones we saw in the last code, but they moved the independent historian up here. So it's not its own category of amount and complexity of data. It's now something that you can pick, and you need to pick 3 from here instead of 2 in the prior slide and for the prior code. So they're ratcheting up the complexity. Okay, well, it's not going to work. There we go, 3. So you need to meet at least 1 out of 3 categories. So you need to have 3 from here, or you need to make it an independent interpretation of tests. So let's talk about that for a minute. The definition for independent interpretation is that there is a reason why you are interpreting this test. Perhaps you have images and you are going to make an interpretation. But if you are separately going to bill for that interpretation, then you would not be able to pick that as a criterion for medical decision making because it's included in the billing code for, let's say, EKG. So the EKG is not only did you do it, but you interpreted it. So you would not use the time, or you would not use the EKG as meeting this category 2 requirement. So you would need to especially document what test, what your interpretation is, which is proper, of course, and that would meet this criterion. The other one is discussion of management or test interpretation with external physician or other qualified healthcare professional. So again, not separately reported, but if you dialogue with, I don't know, the radiologist, no, maybe not the radiologist, or a specialist based on what you're seeing, well, you would be able to document that and get credit for meeting this criterion. So just to review, this is a little different than the prior code. You need to meet 1 out of 3 categories. The categories have a lot of commonality, but there are more factors that need to be met in order to meet a category. Then we move over here to risk of complications. Well, now we're getting into the moderate risk, right? So some examples: prescription drug management, which would be documented and reflected in the note, not just refilling medications. right? Management, is the dose appropriate? Is the patient responding? Those types of things. Decisions about surgery, minor, major elective, things like that. But look, diagnosis or treatment significantly limited by social determinants of health. And this is an interesting change because, as we know, social determinants of health are factors, social factors, and there are a lot of them that can impact how the patient lives and how the patient can be a partner to you in their health. So they focus primarily in the explanation on food or housing insecurity. But there are things like literacy can definitely be a factor. If your patient cannot read a prescription bottle, or even medical literacy from the standpoint that the patient may not understand the necessity, the critical necessity of controlling her hypertension or her diabetes, may not understand the food choices that she's making and how they are detrimental to the proper management of her conditions. So those are some things that there are actually codes for these, and the codes are in the Z55 to Z65 category of ICD-10, and we will include in your packet a list of all of those codes, and you'll see some interesting things. I think I have a slide for that, but I'll show it to you in a second. Let's come back here and look at our definitions, just because I'm committed to making sure that you have these definitions really clear. So one or more chronic illnesses with exacerbation. So of course something chronic illness, which we already talked about, right? A year or until the patient's death, acutely worsening, poorly controlled, or progressing. And so these are things that would be reflected in your documentation and assessment. Two or more stable chronic illnesses, we saw that in the last slide, or the last code. One undiagnosed new problem. So a problem in the differential diagnosis that has a high risk of morbidity without treatment. An acute illness with systemic symptoms, again, high risk. Acute complicated injury, here's a definition for that, but again, higher risk. So you start to see that for the moderate decision making, the level 4 visit, you need to have conditions that are, this is a technical term, out of whack, or quite serious. Let us look at our level 4 category. Remember again, 1 out of 3 now. These have changed. So looking at social determinants of health, problems related to employment. Perhaps your patient is unemployed. Well, that is obviously going to have ramifications for their ability to buy healthy food, things like that. Even come to the doctor, get their prescriptions. Homelessness, a very real situation here in our 2020 pandemic world. Inadequate housing. Perhaps they don't have running water, they don't have heat. Extreme poverty. Of course, foreclosure on a loan. You will probably get a kick out of some of the things that are considered social determinants of health, and they really are. And you're probably wondering, well, how am I going to know these things? Well, you may not. You might create some type of questionnaire that asks some of the major things, or you might delegate this to your medical assistant. Of course, it might seem a little bit like prying. Say, hey, are you homeless? Hey, are you this? But bottom line, sometimes patients really do open up and they tell you what's going on, including conviction in civil or criminal proceedings without imprisonment, and problems related to other legal circumstances, victims of crime or terrorism. So the list is long. We'll be happy to send it to you. These things need to make their way into your documentation and the effect that these social determinants have on your ability to treat and help your patient. Because what you're conveying is that your diagnosis and treatment is impacted and limited by these factors. All right, so moving on to level 5, we see that the level of medical decision making, same thing, 2 out of 3, but we've got highly complex problems. One or more chronic illnesses with severe exacerbation, one acute or chronic illness poses a threat to life or bodily function. Level 5 visits have always been, wow, like one step short of emergency room. These are things that are extremely complicated and very risky and pose, great issues. So not a whole lot new there. Sorry. There you go. Amount of and complexity of data. Well, there's a change again here. So remember the level 4 visit was 1 out of 3. Now we're at 2 out of 3. So this was 3 and it's still 3. These are the same. I don't need to go back over them. Unique source, unique test, independent historian. But now you have to be able to document 2 out of 3. So remember, the same independent interpretation of tests and why you would do that, not separately reported, and discussion of management or test interpretation. So this might not be a very common thing to do, and this might not be a common thing to do. So you might be looking at not being able to meet a level 5 visit based on just data. And remember that you need to meet the criteria in 2 of the 3 columns. So let's look over here. What's going on in high risk of morbidity from additional diagnostic testing or treatment? Well, drug therapy requiring intensive monitoring for toxicity, decisions regarding major surgery, emergency major surgery, decisions about hospitalization or DNR and poor prognosis, so things like that. But let's talk about, well, hang on, we can't talk about that yet. Let's look at our definitions. Chronic illness with severe exacerbation, again, significant risk. Acute or chronic illness or injury, there's a whole explanation here. Threat to life or bodily function. So the drug therapy requiring intensive monitoring for toxicity. The AMA is real clear on this one. It has to do with medications that are long-term, not short-term. Drug therapy, obviously that can cause serious issues. And you're monitoring to assess any adverse effects of the medication, not the therapeutic efficacy. Now that's important because, for example, insulin. Insulin can cause serious morbidity and death if it's misused. But when you monitor the blood sugar of a patient who takes insulin, you're really monitoring from the standpoint of, is it working? Is it enough? Is it controlling the patient's blood sugar? Even if hypoglycemia is a concern, it's really not monitoring for toxicity. Some examples are, let's say a patient in between doses of chemo or cycles of chemo, and you do some laboratory testing to see how that chemo is impacting the patient. Even short-term intense monitoring of electrolytes and renal function in a patient who is on dialysis. So the key to this, at least this example that falls under high risk of morbidity, is that it's not about the patient being on a high risk medication. It's about the toxicity aspect. So that might be helpful, I hope. And I had a blurb for you. which is what I said. Okay, so is your brain like on overload right now? The little table will be helpful, and I think studying it, and there'll be a quiz at the end. Kidding, kidding. But studying it and then looking at some of your progress notes to see how much, maybe you could look at a patient, at what you documented at a patient visit currently and say, wow, what would I have said if I was going to select the E&M code based on these criteria? What else would I have documented or should I have documented? That could be a helpful exercise. So you might be thinking, okay, throw me a life preserver here. And I think there is one. Selecting E&M based on time. What do we know about time? Time in 2020. Boy, could we write a book about that? 2020 and time? Time has an interesting definition in E&M 2020 style. First of all, reporting time has to do with counseling and care coordination that are more than 50% of the visit, right? So I'm sure you know that. The other interesting thing is that it's based on face-to-face time in the office with the patient. So this is probably something that you don't do a lot of from the standpoint that you would need to document the counseling and care coordination and how much time it took, that it was more than 50%. And so that may be a hard thing to reflect. This is based on the 95 documentation guidelines. How does that impact CPT code level 3? Let's look. Typically, right now, 30 minutes are spent face to face. So when you're billing on time, that's kind of like a rule of thumb, if you will, or an approximate. But in 2021, it's 30 to 44 minutes. So you're probably thinking, because I mind read, wait a minute, it's hard for me to get 30 minutes of time spent face to face with 50% of that time being counseling and care coordination. How am I going to get to 44 minutes? Well, there's good news. Time changes in 2021. Yay! Now, well, starting in January, total time will be based on a few other things, not only face-to-face, but non-face-to-face activities that you personally do. The only caveat is these have to occur on the date of the encounter. But let's look at some. Preparing to see the patient. So who doesn't, right? You always review information from the last visit. You review any tests that have come in or consultation notes. For sure, if the patient's been in the hospital, you've looked at all of that information. Well, as long as you did it on the date of the encounter. If you prepared the night before, sorry, doesn't count. But anything that you're doing in preparation of that visit will now count. Even you're reviewing the HPI that your staff documented. Performing your exam, the counseling, of course, ordering tests, but look, documenting clinical information in the EMR. They are going to let providers, duh, right, use the amount of time it takes to document the visit note to factor in to the selection of the code. Hooray! Of course, you know, these things like independent interpreting of results, not billed separately, care coordination, not billed separately. But this really expands the number of activities that now count for time-based billing. Here's the thing. There's always a thing, right? They don't ask you to itemize the amount of time that you're spending, but you do need to document what you did. So don't say, you know, well, it took me 38 minutes on this patient. Well, doing what? You know, I reviewed their prior labs, I reviewed the progress note from the cardiologist, I reviewed their recent echo, those types of things. So you do have to document. And of course, remember one thing. reasonableness. If you saw 20 some odd patients and each one of them took 44 minutes, that results in a very long day, longer than you were there. And every click in an EMR is reflected. So please consider that the amount of time needs to be appropriate and reasonable for the information that you documented and for the patient's conditions and your assessment thereof. Okay, so a summary of the requirements, just something to look at. In terms of total minutes for new patients, this is how it works. Low-level code, if you're time-based billing, 15 to 29, 30 to 44, and on. Now, what happens in those rare instances where you take longer than 74 minutes? Can't imagine it, but there is a code, and actually the code was announced after this presentation, and I forgot to write it down, so we'll include it in your packet. I think it's G2212, but I'm not exactly sure. So for more than 75 minutes, there's an add-on code. And the way that it works is you would bill 99205 with all of your very solid documentation of all these minutes. And then you would report the new code for above the 75 minutes. So you would need 2 codes for that visit. One thing I didn't tell you is that those additional minutes have to occur on the same date as the primary service, obviously. On this slide, you can see that the total minutes for established patients is a little bit different. So 99211 is still available, but there is no time reference for it. But you probably, you wouldn't use that as a provider. Very rare. I did want to tell you that if you, let's say that you have a very, very long visit for this patient. So you exceed the 54 minutes by a lot. Well, every 15 minutes above that, and it's got to be a completed 15 minutes, you would report that additional code. So if it took you, gosh, don't make me do math on the spot, but 30 additional minutes, right, beyond the 55, then that would be 99215 and 2 units of the G2212 or whatever that code is. So that's how you would reflect that, because each unit represents 15 minutes. So side by side, interestingly, you can just see the difference in the minutes. All right, so these were estimates on the date of the presentation. We will look for the link for current payments, but at least what was proposed was quite a little bit of a difference between the reporting of one level code and another. So now what? Well, we would suggest reviewing the AMA information. Definitely email us and we'll be happy to send you a packet of info. Give a look to your pattern of documentation and look at what's needed for medical decision-making coding or time-based coding. You might even do a couple of experiments now that you're aware of it for the next couple of weeks between now and the end of the year. Keep track of how much time it's taking you to do certain things and think about how you would reflect that in the note. That may give you a sense of how to bill and maybe start practicing that. Work closely with your billing staff. Hopefully you've got billing people who are up on these changes and will be able to help you make the changes so that you understand and can implement how you're going to select your codes in 2021. speak with your EMR vendor. How are your templates going to change? What templates do they have to facilitate reflecting the medical decision making or reflecting time-based billing or capturing things? They may not be able to give you a number based on how long you're in that progress note. Remember that there are um, there are activities that you're doing on the same date of the visit that may not occur in the progress note. So, but it's worth a conversation with them because, this is something that they've been preparing for. And if they don't have something or it's not adequate for your purposes, you still have time to create templates that you can use that will make your life a little easier. Contact your payers. And this is something for obviously your billing department, but are they, that normally CMS makes changes and the payers are not too far behind. But sometimes it takes them a while. So are they going to adopt Medicare's changes, especially for the HPI review of systems exam for medical decision making, or do they want you to continue to code based on the 2020 E&M guidelines? That's important because it could affect your payments or your acceptability of your progress notes from managed care payers. They may have other requirements, so it's definitely beneficial. Consider an edit if you have a tendency to report a lot of very, very long visits for that G code for the prolonged detention. Then you may want to consider making a flag in your system that before that code gets reported, somebody looks and makes sure that you really do have all that time documented. And of course, your biller can be your right hand, is your right hand in setting aside some time to review notes and look at some of the changes and how you're going to make them. These are the sources for the information that we presented: the AMA, the AAPC, Medical Economics, RAC Monitor, MGMA, and other industry websites and blogs. So this is how you can reach us. If you have questions, you can follow us on Facebook, on Twitter, LinkedIn. You can sign up for our newsletter. We send out monthly newsletters with I believe it's useful information. And you can always go to our website or email us at info@askccg.com. We'll send you the packet of materials and answer any questions. Thank you, and we hope that this was helpful information for you.